That stuff is right down there, so that's why. But yes, you're gonna crack it away from everyone, away from yourself. Hold it. I would hold it between your legs just in case it shocks you. Have you seen what happens when those things like fall and break the sensor?
Yeah.
It's bad.
It's
cool if it's on YouTube and not happening.
Oh, yeah.
All right, or bleeding. Or cracked. Or cracked. Got to get out of trying to bleed.
Okay.
All right. Make sure our washer's on there. Line up our piss, which is oxygen, which is 2.5. Hand tight, right? Don't go.
And we're still alive, so that's to work well. Yes. All right, good. So opened it up, now we're looking over here. Notice our pressure is about 1900. Again, we want to have 1000. The reason we went and changed that, we probably could have got by with, 500 PSI. I want you guys to get in the habit now, even if you're here, use those tanks. If it's ever under 1000, go change it so that you don't build bad habits. You don't want to have not enough oxygen, okay? And again, this says close the cylinder for the sake of the pre-anesthesia checklist, and make sure you pay attention here for when we do this first exam. You can close and you should close the O2 cylinder. Now when we start with SAM-TIDE, your sim exam 2 and all subsequent simulation exams, in here you're going to leave it open so that you don't get that O2 pressure alarm, because we don't have enough time for the compressor to keep up. But for right now, you're going to crack it, check the pressure, walk back around, and walk over there, turn it off. Okay? The reason that did that is it's not really tight. That's why. Put a little muscle in it.
A little more.
Now check the central pipeline pressure, which we have over here. And again, what would our central pipeline pressure be? About 50, right? Which is our normal working pressure. And it is. We're good there. We would check that the hoses are connected. Make sure that you walk back, that you verbalize all and articulate all the points that are on this. My hoses are connected, they're tight. Make believe that they're up to the wall, or you can look here that they're on the wall, but that they're all connected. Check the initial status of our low pressure system. It's going to be all of our flow control meters. So I'm going to check that they're working, that they're there. I'm not going to go full through the whole gamut, but that they're there. There's no cracks. Visually inspect this, no cracks in the flow tubes. These are all off, all tight, etc. Good. Make sure that your caps are on. It's a good time to check your vaporizers as well. And you can just verbalize that they're full. Okay. Perform a leak check of the, in this one, when we get to 5B, this will be the part where, I'll show you. Perform a load check of the machine low pressure system. Verify that the master switch and flow control valves are off. Okay. I'm going to perform a low pressure leak. This is going to be that suction hole that you're going to connect to your common gas outlet. You would open this common gas outlet. In an ideal world, it wouldn't entrain air if I had the right bulb, but I don't. So you would hold this down, and you can just say that it collapses and it holds for 10 seconds. If you work with these that have an external common gas outlet like these, and you will go to a few places, you want to make sure that this checks, and what this is doing is checking our whole low pressure system, which is here, where my internal common gas outlet, all the way back through the vaporizers, manifold, all the way back through my flow meters, down to the flow control knobs. It's my entire low pressure system. And you'll know that from my flow control knobs all the way out to there is that low pressure. This is what we're checking the integrity of. As it collapses to that, I would leave that there. Then I would open up a vaporizer. In an ideal world, this would come up, and because that's evacuating the air that is inside of the vaporizer. Okay. Notice when this is off, right? When we get into vaporizers, even though this is seated on the manifold, those two port valves that are in the back that this vaporizer sits onto aren't engaged when this is an off. So this stays closed. you've evacuated all the air. When I turn this on, it now opens those, well, this one actually, it goes down, to open those valves up, allows air that's sitting on top of that inside of the vaporizer to be exposed. We would now evacuate that air out. This would stay collapsed again. I would turn it off. I would open this one, same thing, repeat. We're checking every single vaporizer to make sure that there's no leak in them. Make sense?
What if there's a check valve between, like in the low flow system, how would we check the vaporizer leak? Because I read something about if you have the check valve in there, then that check will only check the circuit up to the valve. And I'm not sure if I'm just confused about it.
Yeah, it sounds like you're confused. Really, because this would go all the way to this. The check valve wouldn't change any of that.
So there's no valve in between them all?
No, there is a valve on this. There is a valve.
Okay.
Yeah.
Okay,
I don't know if I'm understanding your question all the way.
maybe not. Slash, apparently these days I
Yeah.
don't speak with English.
Okay. I'm gonna let you judge that one. I'm not sure. Okay, but does this make sense so far on this?
Yeah.
Okay, when that's all done, we turn this off and you'll be done. That's probably the most confusing part of this right there. Does that make sense? Number 6, turn on the master switch. And again, the little stuff, don't go too OCD on it. For example, you turn this on, it says the flow is gonna be 300 mLs. We're looking at the gauge, we know it's not 300. In fact, it tells us 25 to 75 mLs per minute is what's flown. But the whole point of turning this on is that as soon as this machine goes on, we're gonna have some oxygen being delivered through the circuit to the patient. So that when the machine is on and you walk in the room, you forget to turn on oxygen, we're at least administering some by default. Does that make sense? Calibrate the O2 oxygen alarm. Down Excel. We did this last time. You'll undo that. Don't tighten that too much in there. Come to pages, setup and calibration. O2 sensor cal. We're going to calibrate this to 21%. And we wait. And if you wait longer, that means that this little galvanic cell is probably getting close to its end of life. And so at that point, we would replace that.
How long do they typically last?
If you're using, like we're using 100% oxygen in here, about one cohort. So by the time well, not even a whole cohort, probably by the time you're finishing up POA2, you'll replace it. It's pretty simple. This one especially is just like plugging in a phone. Okay.
How much does one cost? Just out of curiosity.
This one I got for like $100. Yeah, it's not good. It's complete. Tight enough, doesn't have to be super tight. And go from there. Now, it says set your O2 low pressure limit, it says, to 30%. Come back in here to pages, alarm settings, O2, this is defaults to 18. So I'll click on that, throw that up to 30%. Reinstall, calibrate daily. And again, this is your only thing, we talked about this, that will prevent us from delivering a hypoxic mixture. Everything else is pressure dependent. Test your flow meters. Make sure that they work through the whole gamut. All the way up, all the way down. All the way up, all the way up, all the way. And then I'm going to cheat. This is why I have this down. So that doesn't go on. This is alarming me that we're at 22% right now. I just put it back into 18% so that alarm doesn't go off. Don't do that for your first one, right? Do it at the 30%. So what I've just done right now is make sure that these work up and down. Now I'm going to check, what is this system called? When I have nitrous and oxygen on together.
Lean 25.
And I check the lean 25. So I turn off the oxygen, nitrous should fall, and it did. Does that make sense?
Mm-hmm.
And I'm going to check the fail-safe. I'm going to turn them both up at 5. This is why you're going to have your oxygen cylinder off so that we can check the fail-safe right now. I'm going to come over here, turn my pipeline off. As the pipeline goes off, you're noticing that this is dropping. My nitrous should fall, the bobbin of the nitrous should fall before the oxygen. bullshit fault. That's a visual, and then what am I going, and that's part of the fail safe, and then I'm gonna see that, what alarm, what's the alarm called? Low O2 pressure alarm. Remember, they're different, those are different things, okay? Now before I just go, I want you all to pay attention to this. Are these bobbins, they're very fine instruments, right? They're calibrated for the gas in these two. Don't just go turn the pipeline pressure back on or the cylinder right now. Turn these off. Turn these all the way off before you come back and turn on your pipeline pressure, your cylinder. That way that initial gas doesn't shoot them up and hit the stops, okay? Now we've alleviated both alarms. Pretty simple. We're good there. Check the initial status of the breathing system. We're gonna make sure we're in bag mode. Our APL is closed right now. Close that, or open that up. Check the breathing circuit is attached all the way here, so you're making sure that there's no kinks in here, and we're going to pressurize this to make sure there's no cracks, but making sure that this isn't kinked, that it's on my inspiratory and expiratory port, that it's at the Y piece connected to the elbow, connected to the mask, to the CO2 sampling line. Why is this tied in a knot?
So there's an alarm.
What?
So there's an alarm.
Explain more.
So this alarm, you're not getting CO2 from the
We're not.
SIM doll.
So it doesn't CO2 alarm. Also, this was a leak a lot of the times because it would have enough gas that would evacuate. We don't want to have a leak in this. So very good. Making sure that's there. What else does the next one say? Oh, verify CO2 absorbent is adequate. You can visually inspect this down here that it's not purple. If you want, you can pull this open. You can all get in the practice of looking at it, taking it apart. These come, I forgot to tell you this last time. These CO2 canisters, you see what the purple kind of looks like down there. It's starting to turn purple. It gets really dark purple. These come wrapped in plastic. Make sure you take them out of plastic. I know that seems redundant. It actually says it on the canisters now when you buy them from the manufacturer because more than just one person was not taking them out. So you take it out. Here's the drain. Remember I said when you replace these, you may see that there's a ton of water down in this little collection part. This right over here is a drain. You can turn this off. When you open this up to drain it though, I highly recommend using a little OR towel or something to collect. It's going to have water all over the floor. Okay. This way, when you put it in here, make sure when you elevate this, you can see there's a little plastic rubber ring that this is going to sit against. Make sure it's not sitting in there all cockeyed, that it's straight, that it locks. I'll get familiar with that. Okay. So we've done that initial status of our breathing system. Test the manual ventilation system and your unidirectional valves. I saw one of you guys had a test loan. Get your test loan. Next, this will be your test loan, okay? This is how you can really visually inspect these valves are working. The other day, when you saw me just have this occluded, kind of the poor man's test, really hard to see that those valves go up and down. So put a little gas in this with my O2 flush, squeeze my inspiratory lung, my reservoir bag. As this expands, you can see that disc stay elevated the whole time. When I expand this, you see that expiratory valve go up, and vice versa. If you're losing gas like this, turn some flows on. Okay, that'll fill right up. You can put a little pressure on the pop off if you want. See, both discs are not sticking. Simple enough. Test our mechanical ventilation system. Leave your test lung on. A little bit of gas. Pop off. Check 500 tidal volumes at a rate of 10. I'm going to fill this up real quick. Make sure that bellows to the top. I'm going to watch this go into that bag, and I got just say a couple liters of pressure. Turn that on. I'm watching this, looking at this gauge to make sure it goes down to hopefully 500. Okay. There's a leak in something. So I want to show you guys something here real quick. Hopefully not to confuse you. Maybe it's just a 2-liter leak. It's probably the scavenging bag. How do I know there's a leak right now, first of all?
Bellows isn't filling.
Exactly. The bellows are not filling. It's starting to come back up right now, so I'm thinking the leak was probably this bag or the test lung not filled all the way up. One way you can tell if that's down there, say this bag, or the bellows, staying down about 300 mLs per time. What you can do is see what flow rate you're at and dial in gas. For example, meaning if I'm at 1 liter of flow, that thing's staying down at, or whatever, staying down at 5, it's not returning to the top. I would dial in from 1 to 2 liters of flow. Does that make this come back up? If it does, I have about a 1 liter leak. If it doesn't, I'll dial in another liter, up from 1 to 3. And is it returning to the top? It'll tell you how big of a leak that you have. You're gonna have leaks out there in a lot of your anesthesia machines. 1 or 2 liter leaks, pretty common, not bad. Okay, we can overcome that. Start to get more, it can become expensive, and you probably got an issue that you probably need to fix. Okay, no O2 pressure. Where's my no O2 pressure alarm coming on? Why?
This is central line.
The pipeline pressure doesn't have capacity. That little thing has not turned on yet. So at this point, what I would do, pull that off with the bellows off, turn this off. This is what it is. Okay? So anyways, we're doing right now our mechanical ventilation. Back to where we were. Bellows are on, they're going, our O2 is at a minimum flow. Other gases are at 0. Now we're going to see that this fills up and down, and we did. Next thing we do is check for stacking. So once this is full, which it is, take this up to 5 liters of flow. Are all of our spill valves basically working? Okay, that's what we're checking right now. Our spill valve is a little valve inside of the bellows. We want to make sure that as we transmit that pressure, it's not going to go to the patient. That gas is going to go somewhere else and not transmit pressure to them by the extra volume. I'm looking here on my pressure gauge. Is this returning back to 0? Or as I turn that gas up, is it going up, up, up? And it's not. So we do not have stacking. This is what you want. Okay? So that's good. We're going to pull back over and check our breathing system. Goes to the top. Pull it off. Leave your bellows always at the top. Okay? I'll take this. So all flows are at 0. Close your APL. Pressurize your bag. I'm going to take my APL to, okay, I'll take it to 40. Or my pressure gauge to 40. My APL is closed. I'm watching this pressure gauge to see if there's any leak. And it's staying about 40. So I don't have a leak. Where am I not having a leak at? My whole breathing circuit. What does that mean? From APL, my inspiratory to my expiratory to my reservoir bag all the way down. There's no leak. This is good. You don't want a leak. This is a very important test. You should, when I say circuit, suction, and blue bag present, your circuit test is really this, your positive pressure. Can we deliver positive pressure? If something happens with that patient, they start to aspirate, you have suction to get that out, we need to take over mechanical ventilation or manual ventilation for them, I need to have positive pressure, okay? This is something you check before every single case. So I have that, it held for 10 seconds. Always leave this on a minimum, right? So we put that on the patient's face, it doesn't transmit positive pressure to you. Replace your circuit back over there. We've done that, okay? Now we're gonna adjust your scavenging system. We kind of did this already. Let's walk over there real quick. You would come over, you would visually inspect that everything is connected, your hoses, your reservoir bag was intact, not having a leak, that your pipeline was connected, and all of that. You turn this valve, the part that allows the vacuum to come here, close it all the way. I said this thing has 2 little holes on it. Just find whichever one, make sure you do 2 full rotations. 1, 2. That is adequate enough to supply suction to your scavenging system. What's that, with O2, says, oh, can you hold the O2 flush valve down for me, please? Watch your pressure, you keep going.
It's been included.
Oh,
Include whiteness.
yeah. Thank you, Steve. No, keep going, hold it down. So this pressure gauge, if you're looking over here, is not going above 10. I just opened the APO because it was going. That's included. And then this right here, we're seeing it not go against 10. Oh, keep holding it. This way. This is why you're going to go through O2 cylinders a lot. Making sure that this is coming out We're evacuating positive pressure here. You can kind of feel it. Real faint, but you can feel it a little bit. That pressure's going there, and you're not seeing it right here transmit back to the patient, okay? Negative pressure, we're not gonna really be able to do. We're just gonna articulate that it happened, but that scavenging system was on. Would we see the pressure gauge over here go negative? And would you hear this or see this working? You're probably not gonna see this work, it's pretty fine. But that you would see the pressure gauge. Again, you're gonna look at that pressure gauge the whole time. That's your scavenging system, pretty straightforward. And then finally, so right now, what have we done? We've checked high, intermediate, and low pressure systems of the ventilator. We've checked that our manual and our mechanical ventilator is working, that our breathing circuit is working, that our scavenging system's working. The ventilator is working, okay? Now we're gonna make sure all our vaporizers are off. Another visual check. All flows are off, my APLs are open and spontaneous, my vaporizers are full, that the caps are off, etc., ready to go. Okay, that's this last one right there. Suction's adequate. Sure, you would check that again. You're going to be putting this with SAM-Tide. The first thing you will do with SAM-Tide is suction, so it's kind of redundant, if you will. When you do this first exam with this test sheet, make sure that you do articulate that suction has been checked, right? Cannot stress to you enough the whole circuit, suction, and blue bag present. Should be good. You're now ready to go. That is a pre-anesthesia checklist, or PAC. Questions? Please, please.
One question.
Yes.
The APL valve,
Yes,
when it's closed, you're giving pressure.
correct.
When it's minimum, it's open.
It's open.
Okay.
Correct. Yep. Other
Can you just show
questions?
us how to build a dam?
For the water? We don't teach dam building in this. You should be able to monitor our lines, central lines, do phlebotomy, do ABGs, and build dams prior to coming. I need to put that on the requirements. Again, and then for this, just make sure, when you do this exam, make sure that you do turn that cylinder off so that you get the O2 pressure alarm. Practice that way. If you see one of you guys are practicing like you were earlier today, and that was good, make sure that you guys catch each other on just the little things. You don't want bad habits, because come in here in the exam, if you can't figure it out, okay, here's the high stakes exam. You look into your, where is it? It's up here. Number 8 is test flow meters, and it says O2 failsafe. If you can't get past that, and that's one thing that you can miss if you leave that cylinder open, you're not going to get past it. You probably fail the exam. I don't expect anybody here to do that, but I've seen it before. And the reason why is because they forget to turn that off because we're using cylinders so much in here. Make sure that you practice this exactly as it says to do right here. If you do that, you'll do fine. And after about 4 to 6 weeks, then all this kind of starts to make sense. Right now it's a lot of information and you're not sure where to put what. 4 to 6 weeks, you will automatically know when it says no O2 pressure how to fix that. This first part, you're kind of like still fumbling and what the hell does no O2 pressure mean, let alone how to fix it and why. 6 to 8 weeks, you got it all down. Okay? Yes?
So we'll, close it, and then once we get past number 8, do we turn it back on so you can continue the rest of?
Good question. I'll tell you to turn it back on if we run into the issue we did today with the compressor not working. As it didn't today and didn't turn back on, then I'll instruct you to turn it back on. And at that point, I will feel confident to tell you, that would be my deal if you miss something. But I need you guys catch it first. Does that make sense?
Okay.
Like that. If that didn't turn on, then I would say just go ahead and open the cylinder. I think that's about it. Pretty straightforward. I think it's pretty straightforward.
Sure.
I'm gonna leave. I made this. You heard me talk about apples, right? You heard me talk about getting one of these and putting all this tape on there. I just made one of these up, and I'm gonna leave it in here. I don't know if I'm gonna leave it in here. I'm leaving this difficult airway out of the room. maybe, I guess I'll leave this in here, but this has all of your regular syringes and stuff and which drugs to draw up for induction, as well as what apples are, okay, concentrations and all of that. We went over in here one of the most dangerous drugs in this top shelf. What is that drug? Phenylephrine. And why is it dangerous?
Because of the concentration.
Okay. This stuff right here, 1 cc is 10 milligrams, which is equivalent to about 100 doses. Okay? And one dose of phenylephrine, 100 micrograms, is enough to cause a baroreceptor reflex in anybody. Okay? Our pressure go up about 20-30 points. Heart rate go down anywhere from 10 to 15 points, if not more. You give 100 of those, you definitely can stop the heart. You may not want to stop the heart, right? So pay attention to that drug. I have it here, this phenylephrine. When you make that syringes, and I know I spelled syringes wrong, I can see that now. Make sure that you dilute that 100 times. How would we dilute that 100 times? So did you hear what he said? Tell us how you would dilute this 100 times.
You have 9 milliliters of NS.
Mhm.
You pull up the 1 milliliter of phenylephrine, and you have 10 milliliter solution. So you have dose. You can,
How much do you have per cc?
So you should have it on.
Hey.
I'm sorry.
How much?
you would have 10 per cc.
10 per cc.
100 per cc.
100 per cc. Yes, yes.
So explain me the math again. This is fine. I want everybody to hear this. This is good.
Drop 0.1 and 10. Yes.
Let him. Go ahead. Tell me again. No, don't look at that. Tell me. This is 10 milligrams.
Okay.
There's a very purpose reason
yes.
why I'm having you do this right now. This is good. Keep going.
So there's 100 mics. Well, it's 10 milligrams.
10 milligrams, 1 cc.
You drop 9 mils of NS.
NS.
And you drop the mil of this.
Okay? Got it.
And so you
Total
now
10.
have a total, you have 10 mil solution,
Uh-huh.
and each cc will be 100 micrograms.
Who agrees with that? Who disagrees with that? Who doesn't know what to agree with and what not to? About 8 people that didn't raise their hand. Okay.
It's 100.
Kevin. A lot of people agree. No, I want you to do this wrong because people think it's just real simple. And what Kevin just did is what? Could have killed your patient. Really?
If it's 10 milligrams,
Uh-huh.
wouldn't that be 1
So
milligram
he
per
made
cc?
a Big Daddy dose. He made 10 milligrams, or he made 1 milligram per cc, or 10 doses per cc. And the math was simple to do that because we weren't even really paying attention, is what I was trying to get at. Thank you for volunteering. This 10 milligrams, you're absolutely right to take out 1 cc and dilute it in 99 cc's of saline, 100 cc bag. Okay? That's how you get the 100 mics. What you did, and it's very easy to do what he did when you first get familiar with this drug or you get in a hurry, or other drugs that you're just not paying attention to that you don't maybe use a lot. And if you were to give a 1 cc dose of that, it's going to have a pretty catastrophic event on hands. And here's the scary part. He's not even going to know why. Because he thinks he did everything right. And he's not alone. You had about 8 classmates with you doing the right thing, but it was all wrong. Okay, does that make sense? Comment. Pay attention to these drugs. Know these drugs. Know exactly how to reconstitute them, exactly what the dose is and what to happen, because that, you're not the first one that you ain't the first, you ain't the last. That's going to happen a lot of times. Don't have it happen on your watch, okay? Preventable. Does that make sense, guys? Who doesn't this make sense to? Raise your hand or ask a question for clarification.
Well, that makes sense, but then you said to put it into a 100 ml bag.
Yes.
It doesn't seem very practical in a moment.
Very practical.
Yeah?
Very practical.
So you have 100 ml bags right there, and you just draw up a cc for the
In
100 ml
fact,
bag?
I have 100 ml bag right here. Yes.
Okay.
Right here.
So are you going to spike a bag or just draw a...
Oh.
No, you
Just
Just
draw
like a grab bag.
draw-
Yeah.
okay.
But you explained a double diluted system of doing it.
It's written down even.
Right.
Right there.
I mean, but that's not using the 100 cc bag, that's
Here's
just
what I would-
re-diluting it in the syringe, correct?
It says 100 cc's.
No.
No.
This is
This
So
is
you're
what Kevin
taking
said.
one of the
Yeah,
hot
it's
and
the
then
same stuff.
re-diluting it in
Yeah.
another
It's
syringe.
yeah,
So you're doing a double
it's a double.
dilution in a syringe,
Right.
but
Yeah.
you recommend doing the.
Here's what I want you to
Better.
do. You can do it in a syringe. Here's what I can have you do. Take this, get a 10 cc syringe, just like this. Take the 1 cc contents, 10 milligrams, squirt it into 99 or 100. Okay, real close. 99, essentially 100 for the math, okay? I'm never taking 1 cc out of this. Taking 10 milligrams and squirting it into a 10 cc bag, shake, shake, shake. I tape the vial around or put something to label it so you don't spike this. Draw up 10 cc's, now I have 100 mics per. Does that make sense? Now I can administer this. I keep this clean. To answer your question, how practical is it? It's extremely practical. I do it every day before I start any case. I make a bag of this. It's now the grab bag for the day. It's now clean. So I save this. This goes in my goodie drawer and it's saved so that if I ever need to make these sticks, I can make 10 of them. It's 10 patients. Oh,
Yeah.
a patient's probably not going to go through this. Right? So that's what I do and I save that for. That's how you do it. Does that make sense? Another way, I don't want to confuse you, but I guess I will since we got this syringe thing going on there for a hot dose and all that. And it's written. No,
I'm
you're
just
right,
doing
you're
what
right.
you
So what another thing you could do, and I've done this, is take a 10 cc syringe of saline, grab a TB syringe, take out 0.1 mLs from that 10 milligram vial. Okay? 0.1, squirt it in a 10 cc syringe, now you have 100 mics per. As long as you know how to do the math, or if you do enough, you're not going to kill somebody. Not knowing, make sure you check your math a lot, because this is very important. And if you do the math wrong, you can definitely kill someone. And if you think you did the math right, or you're just not sure and you do it, you can kill someone and not know why you killed them. And that's really dangerous, because even if you were to give this, say I'm doing an anesthetic, I told you about the OB patient in Texas who a resident gave that to, a whole CC, she arrested on the table. We don't like when that happens. However, that does happen in life. Happened in Texas. It will happen here. We can fix that if we know what happened. One way that we could fix that, if that happens, is this cause vasoconstriction or vasodilation? So I could turn this gas up, turn my flows up, and just douse her, overdose her on a volatile anesthetic to vasodilate. What else could I do in my top shelf? Propofol. Could draw these up and just start dousing her with propofol. Be a great anesthetic as she's in arrest too, right? What else could I do? I could ask one of the nurses if I didn't have any nitro, any cardine or something, to go give me a short-acting vasodilating agent. Maybe. Her heart stopped anyway, so I mean, Esmol is good for heart rate, but I mean, not really for the blood pressure. But her heart's already stopped. But what I'm trying to do is not really kill the high blood pressure, because she's likely arrested at 10 milligrams, is to allow that drug to get, so when we circulate it with CPR, because we're going to be doing that, I guarantee that, we can now make those vessels that are just so squeezed down, we can antagonize that, hopefully. Or we're not going to antagonize alpha-1 constriction. What we are going to do is put other drugs in and make a trash can anesthetic to open up her vasculature, so then have a bigger reservoir to dilute that drug, hopefully.
Viagra, nitro.
What?
Say PD, like Viagra and nitro.
Whatever. I mean, something short-acting that goes away fast. Cardine, nitro goes away really fast. Works really good, but it goes away fast. You know, you don't want to give something that lasts forever, and then you're dealing with that. Does that make sense? But hang on, real quick, but I knew what I did. I knew that I accidentally gave the wrong dose. Now I can enlist a bunch of smart people who know how to handle these chaotic situations. You know, I'm over here trying to do this. Nicole's here, she says, well, start CPR, you're not moving the drugs. Great, because I'm not thinking, right? You get other smart people and let them know, I screwed up. I'm going to try to fix it. I need you to help me fix it too, and we can do it. If I don't know that I gave too much, well, hell, we're just going to watch her die. Maybe we can pray. I mean, you can pray too, but you know what I mean? Think a little bit as you pray. What were you going to say?
I was just wondering, did that patient die, or?
Yeah. People die. Hopefully not on. Hopefully we're not the cause of it, but it does happen. Yeah. Does that make sense? Okay. So you guys are gonna know this. This will help out. Let's go through this. I think we'll be able to get through this one time. Then you guys can do this.